Well, good morning, everyone. This is Patrick Jones from Eastern Washington University, your facilitator for today. Just letting you know that we're going to wait a couple minutes until we get a few more people on board. I think we're going to have at least 70 to 80. So we don't have that many at the moment. We're just going to wait a bit and then we will start because we have lots to go over. So thank you for your patience. All right, folks, this is Patrick again. We're going to start in 1 minute, and I think we'll have many more people trickle in as we get started. So just stay tuned. All right, let's get started. You have before you, in front of you, the usual housekeeping slide. So we hope that it is okay with everyone that this will be recorded. So it'll be available for those who didn't make the meeting on the Greater Columbia's website in a short few days. And just to remind you that this survey that we ask you to do at the end of the meeting is always helpful for planning future events. As one who participates in those meetings, I will tell you that there's quite a bit of thought and work by staff trying to figure out those topics that will be the most relevant to all of you. So welcome to the third meeting of the Leadership Council of Greater Columbia for 2022, and we'll get started. So if you could advance the slide, Stacy. So here's the lineup. We're going to hear from a lot of you. So thank you all in advance from the different LHINs who have put your presentations together. We hope it hasn't been too onerous and given you maybe a good exercise to review just how far you've come over the last few years. We'll take a break about midpoint, a little earlier than midpoint, and then We will wrap up with the final presentations after the break, leaving time, of course, for some questions. So as always, or as we have done for several months now, we'd like to start with a land acknowledgement. And is there anybody on the call who would like to raise his or her hand and say, I'd be happy to read this? Anybody would like to just step up and read these short, few, but very meaningful sentences?
I can do it.
Okay, go ahead, Paul.
We should take a moment to acknowledge that the land on which we live, work, and play contain the archaeological resources and tangible evidence of indigenous peoples. It is the historic homelands of the Yakima, Wanapum, Nez Perce, Colville, Umatilla people who remain committed stewards of this land, cherishing it and protecting it as instructed by elders through generations. We are honored and grateful to be here today on their traditional lands. We give thanks to the legacy of the original people, their lives, and their descendants.
Thank you, sir. All right, we will get started now, but I have to just interject this. This is the first time in recent memory that we have met on St. Patrick's Day. So as I was thinking of my necessary steps to prepare for a meeting like this, I said, well, we had to touch bases to see just how Irish the Greater Columbia area is. And as you can see there at the top, for the data, the most recent data we have is about 58,000 people who claim Irish ancestry. And roughly that's 8% of the entire population of Greater Columbia, which is a bit over 700,000 people who claim to be Irish. And you can see it's somewhat proportional to the sizes, excuse me, of our metro areas. The most Irish community, it appears to me, might be Walla Walla at over 10% of the population. But everyone has a bit of the green in them. And so I don't know what your plans are the rest of the day, but in Spokane, which prides itself with a big Irish population, I think there won't be a lot of work done after 1 or 2 o'clock. Not suggesting that you do that or I do that, but this is a big day in Spokane. So I thought you might want to see yourselves in this bit of ancestry data from US Census. Okay, next slide, please. Okay, somebody's getting dinner ready. I have to confess, I like to cook, but I am not boiling cabbage this evening. So today's session will be a focus on local health improvement networks, I think, as most of you know. And I just wanted to point out the parallel between the LHINs and actually the all the ACHs in the state. And for the Medicaid Transformation Project several years ago, the Healthcare Authority had the option of trying to do this out of Olympia or devolving power responsibility to different parts of the state where that could be done more in a decentralized manner. And the thought was, I think, if I can paraphrase the thinking of HCA at the time, was that the ability of regional groups to understand their needs and challenges and opportunities was actually better than what could be done out of Olympia. So in the course of the grant that Greater Columbia has participated in, the same thought came up about the constituent parts of Greater Columbia's really large swath of territory in the state. We are certainly geographically the largest of all the ACHs in the state. And it's understandable that there would be regional differences, and one size wouldn't fit all. And so I think, correct me if I'm wrong, Diane, 3 years ago, 4 years ago, the LHINs were created. Is that about right? Okay, she's not on right now. I can't put her on the spot, but and over the time, I think it's been a very interesting journey for all those who have been involved in the different local improvement network, health networks. So this is both a check-in, which we have done before, usually in October, and also a statement out about just about a question, perhaps a challenge, that certainly the ACH is dealing with, and therefore the LHINs will be facing as well, since the ACH is funded in many ways the majority of the activities of the LHINs, just how we go forward with financial resources. So today, the presentations you're going to hear are a combination of a report out and some thoughts about what the future might hold in terms of keeping this good work going. So the way if we could just start with the first slide, Stacy, the way we're going to start is kind of in the middle of the ACH on both sides of the Columbia River. Then we're going to focus on the two LHINs that are to the west, entirely west of the river. We'll take a break, and afterwards we'll come back and hear from all those LHINs, actually 3 LHINs, that are to the east of the Columbia River. Thank you, Sharon. The LHINs have been around for about 4 years. I was off by about a year. So starting in the middle with the Benton Franklin experience will be given by Kirk Williamson of the Benton Franklin Health Alliance. And Kirk, the mic is yours.
All right, Patrick, thank you very much. My job is to set the bar low enough that no one has to worry the rest of the morning. And I think I probably accomplished that. Also, top of the morning to everyone. Next slide, please. Benton Franklin Community Health Alliance is the oldest of the LHINs. We were around a long time before the ACH. In fact, the ACH was founded by Carol Moser, who was the executive director of the Health Alliance before the ACHs were created. It was born of a need to create a politically safe environment. The truth is, we are blessed and or cursed by having 3 hospitals in this community, and sometimes they didn't, at least in the early 90s, work and play well together. So the idea was to create a safe place for them to work, first on the Tri-Cities Cancer Center and then on a variety of health issues since. Incorporated as a neutral convener in 2002 and as a 501c3 in 2002. Our priority of things that must be done immediately is, first of all, to maintain our tax-exempt status, because we umbrella a number of organizations, and that includes doing the liability insurance. We also provide the framework for them, for all sorts of people to work together on the community health needs assessment and the health improvement plan, which we're in the process of working on right now. Next slide. Our operations are paid for primarily by the 4 hospitals in Benton County. I left Prosser out of my earlier discussion because they were kind of an innocent bystander in all the machinations that were going on in the 80s and 90s. But that shows where our support comes from, including Greater Columbia, for our annual budget. Next, please. So we provide that umbrella of 501c3, so they don't have to spend time and resources on it. For the Human Services Coalition, Youth Suicide Prevention Coalition, Our health access team, which used to be called HAT, has now been added the word equity, and it really is focusing on health equity. We have a very significant behavioral health committee, the Patient Safety Coalition, and we've taken some time off because COVID kept everybody busy and not able to participate, and also the Oral Health Coalition. Next, please. Things we're doing right now, and the collaborators on the health needs assessment are CADLIC, and we're getting terrific technical support, not only from CADLIC, but from Providence, also the Health District and the Health Alliance. Our partners in that process are Trios, Lourdes Health Center, and Prosser. They do not have to do community needs assessment anymore because Trios and Lourdes are now for profit, so it's not required of them. And Prosser is a public hospital district, and again, they're not required. Our job is to help them see the value and continue to participate in those, in the health needs assessment and in the health improvement plan. Next, please. Here's some examples of things that we've been doing. The wallet card that you see in the lower left below the logo is, well, we printed about, I think about 30,000 of those things in the last year in English and Spanish. They're about the size of a credit card when they're folded up, but they unfold into 6 panels on each side of mental health and suicide prevention information. They've turned out to be very, very handy. And we're willing to share the concept with anybody that's interested in doing it. We work with a local printer. They maintain the content for us so that it doesn't get morphed all over the place. We do on a grant from RDO Foundation, or the Offutt Foundation, and RDO equipment on postvention, which is another way of saying that suicides tend to cause other suicides. And postvention boxes of hope are something that we give particularly to families who've lost a youngster to suicide. They're not something you use right now, but they're something you put on the shelf. And at some point in the intervening months, you sort of get, people get an inclination that maybe they'd like to see what's in that box and process their grief a little bit more. That's when the box of hope comes in very handy. We're also doing backpacks of hope for school-age students. We have a mental health night coming up with the Tri-City Americans on the 27th, a week from this Sunday. It's an afternoon game, so if you're inclined to travel and watch a good hockey game, that would be the time to do it. Starts at 4 o'clock and it's against Seattle. So that's one of the things we're doing, and we'll be handing out those wallet cards and also have a table there in the main concourse. Next, please. What we're doing with the ACH right now is we're continuing to promote Practice the Pause. Last fall, we partnered with the Columbia Basin Badger Club to present Dr. Kira Mosseth, who really is the prime driver behind creating Practice the Pause. She's with the state's disaster mental health team. She did an hour-long forum for us, which is, by the way, on our website. If you want to go look at it, you can Google Badger Club or Columbia Basin Badger Club, and that's where you'll find it. And it is, as you can see, a link on the front page of our website. Next. These are the sort of some of the partners that we work with. We work with nearly 100 different organizations. And I always say that I have the perfect job, which is to say that I get to wander around and meet interesting people who are doing interesting things that add value to the community. And then I get to wander around some more and introduce them to other interesting people doing interesting things. I'll give you an example. Just a couple days ago, I got a call from an old friend who's now the executive director of Columbia Industries, which is a huge sheltered workshop in the Tri-Cities. And they've been kind of quiet for the last several years, even before the pandemic. Eric is kickstarting their engagement in the community. And the first thing I did was think of another Eric, who's Eric Williams with Second Harvest. They're talking to each other, and I hope something really interesting and creative will come out of that conversation. And there are others, as you can see, sort of across the board. Next, please. Here's our sustainability strategy. Keep doing good work and make a difference in the community. If you do that, you don't have to worry very much about sustainability. I have been called more than once the Dr. Kevorkian of nonprofits, because I think when a nonprofit reaches the point where it's no longer worth the amount of resources the community puts in it, it ought to go away. In the meantime, I offer the words of the Lorax as my parting comment this morning. Unless someone like you cares a whole awful lot, it's not getting better. It's not. I'd be happy to take questions if you have any. Otherwise, thank you for your time.
So any quick questions of Kirk and the Benton Franklin Community Health Alliance? I'm looking.
Just a quick comment, Kirk. I just think you set the bar really, really high. Just
there you go.
Thank you, Dan.
Okay, no pressure on these next folks coming up then, Dan. We'll think about if you have questions, and what I'd like you to you may have specific questions of the presenters, or you may have some general question of some or all of the presenters. So just think about those. And I think those of you who have been with us over the years know that this is an important part of what we do, is not just to listen, but to actually participate in a dialogue. But I don't see any more questions or hands up. So we will go on then to Kittitas County. So Robin, I saw you check in. Robin Reed, are you there, ready to go?
I am here. Good morning, everybody. I'm not sure, am I using my own slides and sharing my screen, or is somebody pulling my slides up?
Someone is pushing your slide deck forward, I think. Stacy, are you ready to? There we go.
Yep, I have it. Whichever you prefer, you can share your screen.
Okay. No, that's fine. That's perfect. Okay. Just a minute here. Okay. Well, good morning, everybody. I'm always thrilled to present about Kittitas County Health Network because I think we have a really amazing group of people who do great work. So it's exciting to talk about it and to be in a position to be able to support it. My name is Robin Reed. I'm the executive director of the network. I started with the network in 2019. I was the first staff person hired, but the network actually started back in 2015 with a group of people called the A-Team that started doing some care coordination. And then they got together and created, more of a broad health network and applied for 501c3 status in 2017. So all kind of around the same time that the LHINs were also being created. And so we were kind of the natural fit to become the local health improvement network. Next slide, please. So who are we? I was asked to put a bio. I'm not going to read my bio. I'll let you guys read that if you are interested in my background. But the network is really this collaboration of all these wonderful organizations in our community that provide health and social services to our community members. It's very much a cross-sector collaboration. We have schools, we have law enforcement, we have public health, we have healthcare, we have early childhood, early learning, we have emergency response, substance use disorder recovery services. So definitely a cross-sector representation, and was intended to be that way from the very beginning when the A-team kind of had the vision of establishing a rural health network. The pictures you see are my wonderful staff. There's 10 of us, and actually one person in those pictures has left, and we have just hired a new person. So it's not completely up to date, but also have wonderful staff. We're very, very lucky. These folks have experience in our community. We have 3 community health workers on staff. We have 2 care coordinators. We have people who have experience facilitating community groups, and then people that have, extensive background in public health and in public health leadership in our community. So that's who we are. The staff, we are here to serve our community and to serve our network partners. So when we're talking about who the network is, it's really, the collaboration of organizations in the community. Next slide, please. So our vision is that all people in Kittitas County are supported in achieving health and well-being. It's very broad, but it's something that we believe in strongly, and that all of the work that we do is really tied into. What we really want to do is be looking at how to break down barriers in our community to accessing services, how to make it easier for people to make healthy choices, and provide the supports that that really at some point in our lives everybody needs to be able to achieve health and well-being. We do this through our cross-sector collaboration, and so we really believe that by partnering with each other and really formalizing our collaboration, we can improve coordination of services, we can improve communication amongst our partners, and provide services more effectively and more efficiently. We also really try to focus on a systems level. So we're really trying to build a system within our community that provides services kind of collectively and together, and coordinated. It's a big vision, and one that we'll probably always be striving for, but we have made a lot of progress in this area of just, creating that sense of coordination amongst the different services. So a lot of work to go, but it's made some big changes already. Next slide, please. So just a little bit of an overview of the Kittitas County Health Network. Our board of directors, right now we have 14 members. Our board is made up of mostly higher level leadership of the different organizations that participate in the network. This was actually done very intentionally. We had some past efforts in our community of trying to create similar collaborations, and we realized that what we were lacking in all of those instances was strong leadership support and involvement. We had the people who were on the ground, who were really passionate, who knew a lot about the community, who knew, the services, but we had lacked to really engage agency leadership. So creating our board of directors this way was really intentional. The Leadership Council it is really modeled after GCACH's Leadership Council. So it's really where the network started. So when the A-team started looking at wanting to create a network, they started creating the Leadership Council essentially. And it was really made up of folks within the community who were really knowledgeable, but also really passionate about population health in general. So maybe they had a niche and some specific expertise in their area, but they wanted to be able to apply that expertise broadly to the community and impact community health by collaborating together. We have about 38 cross-sector organizations participating currently. We have 6 work groups that I'll talk about here in just a minute. Since 2017, we've been awarded around 2.7 million, and some of that has yet to come in. We're still working on spending it. We have a couple of longer-term HRSA grants, but have done a lot of grant writing and a lot of work to bring in those funds to our community. We've got about 75 people total that are participating in the network between our work groups and our board and our leadership council. And then as you saw, we've got about 10 staff, 8.35 FTE. So some of us are part-time. Next slide, please. So our work groups, this is where the amazing stuff really happens. So you've heard me mention the A-team. It's really where the network started. It's a group of service providers who got together and really said, you know what, we have people that we're serving that are in common, yet we're not talking, we're not communicating, we're not sharing information. And that's doing a disservice to the people that we're serving. We're making it more difficult for them. And so they started getting together once a week and really talking about the services they're providing and troubleshooting and brainstorming and problem solving to be able to best serve the people that they were working with. And the population that they're working with primarily at that time and is still kind of primarily the population that we're working with are folks that maybe were calling 911 a lot for things that were non-emergent or things that could be preventable, or showing up in the emergency room for similar reasons, or maybe, you know, getting out of the hospital only to be readmitted a week later. And so it was really looking at these folks and saying, you know, we don't have to be using our emergency system for some of these things. We really can take care of some of these issues by really just going to their homes and seeing what it is that they need and meeting those needs. And so that's what they started doing and are continuing to do today. And with funding sources, we've been able to hire paid care coordinators who then work with the A-team and have really been able to expand the level of service that we provide. We also have paid community paramedics that work with the program, and they are very, very integral to the program, not only in referring to the program, but they are also the ones who make a lot of those initial contacts and do some assessments on folks to really identify what their needs are. Our substance use disorder work group has primarily been responsible for increasing access to medication for opioid use disorder in our community. We went, and I don't have the numbers off the top of my head, but I know that we went from basically like 1 or 2 providers who provided this service to, I mean, I think we might have 10 now in our community. And those services are now located at 2 different clinics as well as in our county jail. They've also provided a lot of community education. So just really working to increase knowledge and decrease stigma about substance use disorder, not only among the general public, but also among families, friends, supporters, and among our health and social service providers. Our behavioral health committee actually started kind of outside of the network, but then kind of came under the umbrella of the network. And they really came together in response to just seeing a lot of need, especially around youth and how difficult it was to access services here. This group is responsible for passing the 0.1% sales tax increase for substance use disorder and mental health treatment in our county. This has been an effort that has been underway for at least 10, if not more years in our county, probably since 2005 when the RCW was put into effect to allow this. So it's been a long effort, but the creation of this group was really what made it happen. This group of people really hit the streets, started talking to policymakers, doing community presentations, and really pushing to get this passed. So this was a huge win for our community. We have a group that focuses on ACEs and resilience, and this group was actually started by the Public Health Department with maternal and child health funds. And so we kind of do some cross-sector collaboration in helping with that group. They do a lot of trainings and train the trainer trainings, basically to kind of get messages out, try to increase knowledge and awareness about the impact that ACEs has on our health, as well as working to build resilience in our communities. Our childcare work group, this is a priority that was identified in our community health improvement plan back in 2017, 2018. And then last year, we received some funding from the Department of Commerce to do an assessment and planning process around childcare. And that really allowed us to jumpstart our work in increasing access to quality childcare in our community. So that's been a really exciting endeavor, and we received another grant from Commerce this year to work on implementing some of the work that we, implementing some of the plan that we did last year. And then we also have an assessment committee, which is a group of folks from our network organizations that are really data minded, and we use them as kind of a consulting group to work with us. You know, anytime we're working with data or doing assessment, and kind of running things by them and getting their feedback and help with that. Next slide, please. So I'm just going to talk really quickly about our community health assessment. I've got a couple of just broad overview slides. Our community health assessment was done in 2017, 2018 with the network. The health department had done one 5 years before that, and then collaborated with the creation of the network in 2017, 2018 to complete another community health assessment and improvement plan. And then this past year in 2021, we did kind of an update to that assessment and improvement plan. And we'll continue to work with our partners in the future to update and then also do kind of another full process. So just a little bit about our community. And actually that's a typo. Our population is closer to 48,000 right now. We have one of the fastest growth rates in Washington state. A lot of people coming here to retire, a lot of folks that have moved here to live here and work somewhere else, commuting and now remotely quite a bit. So definitely people looking for a certain quality of life that we have here in Kittitas County. Population is 84% non-Hispanic white, about 9% Hispanic is our largest ethnicity group. Median age is actually quite low compared to a lot of other counties, in good part due to the presence of a major university, so Central Washington University. About a quarter of our population are Central Washington University students. And 45% of our residents live in unincorporated areas, so in either small towns that are unincorporated, or the more rural outlying areas that are outside of the towns and cities. Some of the assets that we have here in Kittitas County, we have really good access to recreation opportunities. We're kind of right in that crux between the mountains and the desert. So you can get a lot of variety of recreational opportunities around here. We're generally seen as a really safe community. We have low crime rates. People feel like this is a good place to raise children. And feel generally safe coming here. We have pretty good life expectancy. We have higher life expectancy than the rest of the state. And we also have low rates of low birth weight babies, as well as low teen birth rates. Next slide, please. So a couple other things that our community health assessment noted just in terms of need, we do have high poverty rates. Some of this is driven by the presence of a university. So we have people that are pursuing their education and maybe not bringing in as much income, earned income. But this also applies to children. Our child poverty rate is also quite high. And we know that in some of our more rural communities, the poverty rate is high as well. Housing is a huge problem here. Not only is it very difficult to find even just available housing, but then being able to actually afford it. Our housing prices have really been driven up by the increase in growth in our county. And so this is really a big concern in our community. We do have higher than average rates of STIs, as well as increasing, might be partially due to just our younger population. We are a health professional shortage area in primary care, mental health, and dental. And I want to talk about mental health and SUD just because that is really one of our primary concerns in our 2017 assessment. Those were really identified as primary health issues in our community. And so those are areas that we really focus on, even in our care coordination efforts. You know, a lot of the folks that we work with are struggling with mental health or substance use disorder. And one of the things that really hits home, and this graph doesn't really, it's hard to see it because it almost, if you just glance at it, looks like a flat line, but our rates of depressive feelings and suicide ideation and even suicide attempts in our youth have been increasing. So for example, the triangles, the gray triangles considered attempting suicide, that has increased from about 12% in 2008 to closer to 20% in 2018. And so if you really think about, you know, percentage jump, like that's pretty big. And so we're pretty concerned about some of these areas, which is why mental health and substance use disorder are some of our focus areas. Next slide. So what does this mean for our community health improvement plan? Our community health improvement plan, we used a framework called MAP, which is Mobilizing for Action Through Planning and Partnerships. And one of the phases of MAP when you're creating your community health improvement plan is to identify really high level strategic issues. And you kind of pose those in terms of a question. So our first strategic issue is really about how do we improve the delivery of healthcare and social services in our community. Our primary goal here is that people get whole person services, care, and resources efficiently and effectively. How are we doing that? Through establishing a community-based care coordination system. By establishing these cross-sector work groups, one of the primary benefits of these work groups is really just getting everybody together to talk about what they're doing, what they're seeing in their fields, and just get everybody on the same page and communicating about their work. And then also just increasing services around prevention, screening, treatment, and recovery services for mental health and substance use. Next. Our second strategic issue is around addressing social and upstream factors that affect health outcomes in our community. And we have a couple of goals here. One is just about increasing awareness and understanding about how social factors like housing, income, transportation, as well as things like childhood trauma and community resiliency affect health and well-being of individuals and of our community as a whole. And then the other goal is, again, around childcare, because that was a specific issue that was brought up in the community health improvement plan. So that has its own goal. And that's really that quality childcare is widely available and easily accessible, not only for families, but also knowing that it has an impact on employers as well. And so employers are heavily engaged in this effort. Our strategies here around ACEs and resilience is really, a lot of community education and awareness, and also just engaging with different activities in the community that are building resiliency, or, working with our partner organizations to provide services that are trauma informed. And then the childcare work, again, focuses mostly on just increasing childcare options in our community, as well as engaging employers in supporting different childcare efforts. Next slide. And then our third strategic issue is all about sustainability. So there was kind of an intentional recognition when the network was being developed that we needed to really call out the fact that if we want this work to continue, we have to put significant effort into building the network, making sure it functions at a really high level, and that it's sustainable for the long term. And some of our strategies there, this is really actually comes from our strategic plan that we just completed last year. And it's really around making sure that we're continually fostering meaningful participation with our members. So not only getting new people involved, but making sure that the folks that are involved, that they feel like it's a good use of their time and that they see the value of being a part of the network. Another one of our strategies is developing and utilizing our key metrics. So really focusing on that data piece to make sure that we can tell the story about the impact that we have. Intertwining health equity and people with lived experience in what we're doing. So this is kind of a little bit of a newer initiative that we're really trying to focus on in bringing that into all the work that we do, as well as identifying areas in our community that we can have an impact on. This is where we really got involved in COVID work. At the beginning of the pandemic, the network really didn't have much of a role in COVID besides in the individual agencies. But as the pandemic progressed and inequities started to surface, that's kind of where we started to identify our role and said, you know, those are areas that we can help with, that we can do something about. And this is where we've brought on a couple of community health workers that really go out into our Latinx community to spread messages about COVID testing and about vaccine. Our community health workers are truly amazing and have been solely responsible for getting at least a couple hundred people in our community vaccinated over the last couple of months. So that's been really exciting, especially this late in the vaccination game. So they are quite phenomenal. And then finally, just sharing the value and impact of our work. So knowing that we need to have buy-in, we need to be able to show the value of what we're doing so that agencies and funders, you know, see the value of supporting the work. Next slide. And just a little bit more about sustainability, more related to funding. You know, right now we do a lot of grant writing. We have kind of some future goals to expand some of those efforts into looking at more corporate and foundation funding. Right now, we're mostly doing, we do a lot of HRSA grants and more local government grants. But to truly be sustainable, what we're going to need is local investment and strong support from our community partners that see the work that we're doing with the people that they are serving and how that has an impact then on their organization, the services they are providing, and reducing the cost of those services as well. So that's kind of the direction that we're headed and going to start talking about a lot more, is just, you know, how do we engage our network partners and members in supporting the network and bringing in that support so that we can continue that work that ultimately has an impact on the work that they do. And there is one more slide with just contact information, but that's all I've got for you all today. Thank you so much for listening. Feel free to reach out at any time if you have any questions for me. Thank you.
Thank you so much, Robin. That is a lot of activity for a county of less than 50,000 people. So congratulations. Any really quick questions of the Kittitas experience before we shove on? Looking at the chat.
I told you I was setting a low bar.
What's that, Kirk?
I said that I told you I was setting a low bar. That's a great presentation, Robin.
Yeah.
Thanks.
Thank you very much, Kirk, but definitely not a low bar. You guys have done amazing work too.
All right, well then, in the interest of time, let's move on a little bit to the southeast and hear from Yakima, the healthcare coalition in that county. And we have two presenters, I guess, and I don't know whether Rhonda or Dan will lead, but for now, the mic is yours.
Thank you, Patrick, and thank you both to Robin and Kirk for setting the bar really, really high. I'll make sure that this is short and sweet. So go on to the next slide. So Ron and I are co-chairs of the Yakima County Healthcare Coalition. And you can read about both of our kind of abilities to serve in this role. I think the point that might be important to make here is that we are both volunteers, and everyone who participates and you know, our member organizations are volunteer organizations. And so we meet twice a month generally, and we rely on the interest of member organizations to suggest topics. And we'd like to think that we're bringing both statewide lens as well as regional lens, for example, through our work with the Practice Transformation Work Group and our workforce committees, and role with the Greater Columbia ACH to our conversations with our member organizations. And so we bring lots of interesting topics. Go ahead and go on to the next slide, please. As you can see, we have a very broad, diverse group of organizations involved with our coalition, human service organizations, hospitals, universities, mental health organizations, other healthcare providers. And I think the important piece here is the recognition that we're all very, very interested in addressing the needs for our community and for being innovative. And we hence do a lot of problem solving, a lot of thinking out loud, a lot of kind of creative thinking about what's the best way of meeting the needs of our community. Go ahead and go on to the next slide, please. So in our community needs assessment, we identified housing, behavioral, and mental health and education as our top needs. Next slide. And you can see by where we directed funding, you can see that those are the areas which we really targeted the funds in partnership with the Yakima Valley Community Foundation. I would want to say that that third bullet there, housing and justice, I think are really important because we do a lot of work with legal and medical partnerships. We bring in our legal community to really help guide a lot of our strategies with our coalition. And go ahead and go on to the next slide, please. So these are just some examples of how we're addressing the need in housing. For example, we provide emergency shelter support. We have permanent supportive housing. We've had employment services for people experiencing homelessness. And in the behavioral mental health realm, we do a lot of outreach and awareness. We've developed a resource handbook. We've recruited and trained teachers in high need schools. We provide early intervention behavioral health for children and therapeutic childcare for patients in treatment. And in the education space, we've developed awareness campaigns for job training for DD clients, education training and well-being of underserved youth, adults, and honored citizens. And we've provided legal representation, helping children transition back to school. And I guess the other thing is when you look at that list of members, and again, I'll just reiterate how important, you know, partnership and collaboration and coming together on a regular basis to do problem solving, to think out of the box, to think about how we can meet the needs of our community. So other examples that we've worked on are things like broadband access. Certainly the coalition has been very involved with the public health response to the pandemic. And an example of that is just being involved with what we would call a masking campaign or counting masks at storefronts every other week. We've kind of in a whole different area working with our university and college partners, looking at workforce development and innovation in that space with interprofessional education, and how can we kind of tighten up the partnership and collaboration between health professions. because most of us are in the human service and healthcare space, we're very interested in health workforce development. And that's an area, of course, that I'm really interested in. And so we do a lot of problem solving and kind of strategizing about meeting the health workforce needs of our provider organizations. Next slide. So kind of reverse of what others focused on, our mission is to advocate for the healthcare needs of the people of Yakima County. Our priority is to assure services are available to the disproportionate share of the state's Medicaid population living in Yakima County. We've met since 2000, the year 2000, as a coalition. And again, we're volunteer organizations, and we're supported by the collaborative interest and the commitment of the membership. And I just think that's a really important piece to emphasize. And that is, by and large, we're 100% volunteer. And we see this as, in some regards, sometimes our well beyond our day job that we're working on or working with this coalition. So with that in mind, I'll just pass that back to Patrick and be happy to answer questions.
All right, folks. Dan, thank you. You got through that with a little time to spare. So let's not be too bashful. And if there's more you want to talk about, go ahead. Or if there are specific questions right now for Yakima County's experience, that would be welcome to raise your hands and ask away. I'm looking in the chat box, Dan. I don't see anything yet. Anybody have questions of Dan?
And I would welcome any of my partners to chime in, Angela, Sandra, or Lindsay, if they're interested in contributing to the conversation.
Okay, thank you, Dan. Fellow Yakima residents and community leaders, any quick comments to Dan's presentation? All right, well, while you people are still putting your thinking caps on, I've had my thinking cap on a little bit, see if this gets out there. This is for all three of you. And not just because I do a lot of data work, but I think it's important to, for the sustainability of an organization, to be able to show value to your existing and potential funders. So how do you measure progress in your three different enterprises or endeavors? Is that something that is easy to do? It's been difficult to do, or do you do it? So how do you point out to your funders that you're moving the needle a little bit? Anybody want to take a crack at that one? I know that might be a hard one, but I think it's something we should think about.
Patrick, because we operate a little bit differently than some of our companion organizations, we typically depend on the health district to do most of the measurement. I'm a staff of one half of it. That's it.
Yeah.
So our job is really to move the needle by moving people to get to the table and find ways to creatively solve community problems. And we can point to lots of examples where that has happened. We worked with the Three Rivers Community Foundation to identify and then fund significant chunks of work around the three biggest priorities of social determinants of health over the last couple of years as part of our work with ACH. But in terms of directly measuring, not so much, more anecdotal.
Okay, fair enough. Appreciate that.
And I would, sorry, I'd have to agree with that. A lot of it is anecdotal and kind of what we're doing for example, if we are identifying at the state level or at the regional level challenges, then we are bringing those topics to our coalition to, locally do problem solving and strategizing about what was going to work or what is going to work. I see Lindsay on video now. She might be able to respond to some of that question, Patrick. How about putting that? I can put her on the spot.
That, we almost planned that transition because I was just about to hit the raise my hand. So we'll just tell everybody that was completely on purpose and we coordinated that. Hey, everybody, I'm Lindsay Boswell with the Yakima Valley Community Foundation. And we get the pleasure of working with both the Kittitas and Yakima LHINs on helping distribute some of the community-based grant dollars. And the thing that we have started to do for evaluation and assessment and measurement on our end is we have moved to an interview-based grant reporting format. So for all of the grants and outreach that we do, we have a conversation, which, launching that full scale in the middle of a pandemic was probably not my original plan for how I would do that, but it has helped us gather way more info in probably a more useful format than we'd ever had before. And so that's been really helpful. And we've really appreciated all the partners, many of whom, are in the LHINs who've been willing to practice that process because it's a little weird when you're used to just sending in written reports. So from our standpoint, that's been something we've been able to do within this partnership that I think has been really great. And we've gotten great feedback from grantees and partners that it's a much more meaningful experience also.
Okay, thank you, Lindsay. Robin, any comments to that particular question? I know you talked about an assessment committee.
Yeah, I don't know that I have anything really much else to add except that it's really hard. I think that, that part of our work has been a struggle, not only to find the resources to put behind, identifying the measurements and making sure that we're, following those measurements, but, the energy is around doing the work and providing the services, and folks that are on the ground providing the services, they see the impact it makes. They don't need a number to tell them that. They see the difference that they're making. And so it's an area in which I always think, man, if I had, a couple of full-time people to just focus on assessment and performance measurement and, data analysis, we'd be great at it. But it's definitely kind of a constant struggle to feel like we're doing what we should be doing and to keep up with that side of things.
Okay.
Yeah.
Thank you. Yeah, no, that's a fair and honest response. So we still have a few minutes before the break. Any questions of the three presentations and the presenters?
Patrick, I just have one thing I'd like to add. Apologize for
Sure.
interjecting here, but I would be remiss if I didn't talk about the work of our PAM project, the patient activation measure that we have kind of rolled out to a number of organizations. And that does, of course, have the vendor is able to use or do some really solid assessment about the utility of the patient activation measure and the impact or effect it has on patient engagement and wellness. And so I think within our various strategies or projects, we do have assessment measures.
Okay, thank you, Dan. Any comments from all of you, questions from all of you about the three presentations? Well, let me exercise the power of the chair to ask one more question of all three of you. And this is putting on my leprechaun hat and imagining that there is something at the end of the rainbow, and that if you could find that end of the rainbow, what would be the one obstacle that you'd like to remove to get rid of any just hesitation and sort of breaks to your organization's success? What one thing would you do to up the game of your particular endeavors? You guys have thoughts on that? If you could, is it just a question of money? Is it a question of trust? Is it a question of anything else? Any thoughts on what would be a good strategy to remove that big barrier to further success?
I would remove about 30 miles of county line between Benton and Franklin counties.
I would really focus on building community trust. And in my particular area, I would really try to elevate the importance of community and family involvement in encouraging workforce and economic development. And when we think about helping young people make decisions about careers, and particularly in healthcare, I think it's incredibly important to pay attention to the role of communities and families in supporting those opportunities.
Okay, thank you, Dan. Robin, do you want to move the boundaries of Kittitas County like Kirk, or are you okay?
No, I'm okay with our boundaries. That's a really tough question, though. I think actually what Dan just said kind of led me to mine, which is that I think we need to move on from the low-hanging fruit, I guess. Not that what we're doing is easy, but look for those, really, really intentionally look for those inequities. We tend to, in Kittitas County, everything's kind of centered in Ellensburg, but yet, a good majority, over half of our population lives outside of Ellensburg. And so, really kind of shifting our focus from what's the most convenient and what's the easiest to where's the need the greatest.
Okay.
Our counties have a history of racial division that goes back really to the beginning of the Hanford Project, in which people of color were not allowed to live in Richland. And as you know, Patrick, we still see the results of that in our community, in that Franklin County and Pasco are largely non-white, mostly Hispanic, and Benton County is largely the opposite. And how to bridge that gap is probably would be the #1 priority, because it affects every kind of measurable quality of life issue or health issue that you can have. And it goes across the entire community. We've been looking at 2 census tracts actually in Richland. They're about 0.3 of a mile apart, and the life expectancy difference is 13 years.
Wow. So
how do we address that? And then the inequities that extend across the river.
Mm-hmm.
And it would only take a couple of zillion dollars to fix.
Yeah. Well, as it was explained to me, Kirk, when I first started working in the Tri-Cities, he says, we're not called the Tri-Cities for nothing.
Yeah, no, you're absolutely right. You're absolutely right. What's really interesting now is that Pasco, which was always the smallest of the 3 cities, has now surpassed Richland in population. and is growing so fast, it's almost scary.
Right. Yep. Yep. Any last minute questions of our panelists before the break? These are wonderful to learn about. There is so much going on in these communities, and I think the wisdom of having county-based or in the Tri-Cities bi-county-based endeavors is so right on. So it's been great to hear your stories and hear some of your thoughts about what the future might hold for you. All right, well then let's take a 10-minute break. It's 10:10. We'll come back at 10:20, and we will start with Martha Landman from Southeast, then move to Walla Walla, and end up at Whitman. So don't grab the green beer quite yet, but come back in about 10 minutes and we'll keep on going. All right, folks, we will get started in just a minute. So grab your coffee cups, whether it's Irish coffee or not, just sit back and enjoy the presentations you're about to see from the three groups in Southeastern Washington, and let's all learn from each other. So we will start momentarily. All right, let us begin again. And we're going to start with the Southeast Washington Alliance for Health. That's quite an acronym, I have to say. I don't even know if I want to pronounce that one, but I'll let Martha walk us through both the pronunciation as well as what is going on in those three counties when it comes to local health improvement network. So Martha, the mic is yours.
Thank you. The acronym is CWA is what we call it in our three counties. Thank you for letting me present today. Kind of feel like the new kid on the block, because everybody that has talked so far is much further down the road than our group, but glad to be here and glad to gain this experience from them and be able to look at the future and see where we could possibly be in 5-6 years down the road. Next slide, please. Just a little bit background about myself. Main thing is I'm coming from public health and starting in this job. I've been in this job 4 months today as a 2/3 executive director of Southeast Washington Alliance for Health, and glad to be here in the nonprofit world and looking forward to all the different things that come with this. Proud to be from Pomeroy, born and raised in Pomeroy and Garfield County, and from two families that are centennial farmers in Garfield County, so long heritage in Garfield County. Next slide, please. So a little bit of history on the Southeast Washington. As we started while I was at Columbia County Public Health and we started putting together a group, just talking about how we could do better working together on healthcare and what challenges we had together that we could work on together and possibly apply for grants together and just work together, which wasn't happening across the counties before then. So we started with Columbia and Garfield, and then invited Asotin to join us, and that has really been a benefit to be able to work in all three counties and to be able to see the needs in all three counties. It's also a challenge because of the mileage and the physical size, but getting the partnerships together across all three has been really good. And we did a combined needs assessment in 2019 and are scheduling to do another one here in 2022. To see what has changed and to move on into community health improvement plans from there. Next slide, please. So as far as sustainability and what we are doing, we have some leadership meetings with 18 to 25 people. We were meeting in person before these last COVID-19 restrictions. And so we are meeting via Zoom now monthly and just have local needs. A lot of the meetings have been focused around COVID-19 and what the needs are and where are the gaps in each of our communities. And can we help each other in our communities to work together. I think one of the benefits that the LHIN has proven throughout this whole COVID-19 is having those monthly meetings, being able to share experience with each other, and being able to share supplies across the different counties that I don't think would have happened if we weren't all working together and had built the trust and built the camaraderie between us before the pandemic started. So a couple examples of that is a couple of different times Columbia and Garfield had run out of testing supplies at the hospital, had run out of the state supplied testing supplies at the hospital, and contacted and talked together and reached out in some of my county meetings and told us that they were short, and then consequently could share some resources back and forth between them to get supplies back and forth so they didn't expire in one county and sit on a whole bunch and the other county was purchasing supplies. So that worked multiple times, and most recently worked between Garfield and Asotin County. And I think that is just the beginning of what this partnership, the Southeast Washington Alliance partnership, will be as we go forward. The other thing that we have done really well together, let's go to the next slide. I think it's on there. So here's some of the funding that we've got. So realize that we're only, May of 2020 was our official nonprofit date. So we've been in business, really didn't put anything in the bank till 2021. So we're a year and a half into some of the different funding sources. And what I find really interesting about listening to these projects this morning is that I'm new to the nonprofit. So this is sustainability to me. I'm an analytical person, so this is what I work on. And this is just the stage that we're in. I feel like in our LHIN is still working on where our money is going to come from, where we're going to get started, how we're going to build momentum, how we're going to build the trust between each other, how we're going to build that collaboration, and not yet to, and look forward to being where Robin is with a strategic plan in 4 or 5 years, and being where we can make changes with our community health assessment. We had done a community health assessment, and we're working on a community health improvement plan when COVID-19 hit. And so we're going to kind of reboot that process and start that process over with new data to meet the needs of the communities. We've got some HRSA funds is what allowed us to get the nonprofit started, a networking grant that helped us to do some real good network things in the beginning to get our partners working together. We've got some group health funds that have really helped our communities throughout this COVID-19. You know, we allocated funding to each county to be able to use, the board members in each county to be able to use. Some examples of that would be, you know, these are buying special ed needs around more active kids in the PE room, that they can't really do keep up with the other kids, or not really getting the physical activity that they need, and needed different equipment to do that. During COVID-19, there was some exercise equipment that needed to be done and purchased in Garfield County in the school gym, so that people could still get exercise in our community while during the COVID-19 breakdown. We also bought a freezer for the food bank and bought some protein. They were short 2 months out of the COVID-19. There was no food bank, didn't have any protein, no meat, no anything to give out through the food bank. So we bought some protein to make sure that our food bank recipients had protein in in their boxes every month. So lots of little grants that we have done. We've helped with COVID-19 sanitizer and things like that, and things for our restaurants when they had different requirements come by. But the money has really helped our communities, really been spent where the community said, hey, I need $5,000 for the food bank to upgrade, to get IT equipment. Didn't have any IT equipment, and all of a sudden had 5 grants they were managing and didn't have any way to do that. So I'm on the end. The group health grants really helped us to do those little things in our community and build, and that's helping me build coalition and build trust in our communities and kind of build, I think, the groundwork that will get us to some bigger projects as we go through. One of the projects that I'm looking at that is kind of my passion is we have seniors, more seniors over 65 in each of our communities than the state average. The state average is about 17%. We're at 25%, projected to 32, 33% in the next couple of years. And so I'm looking at how we can keep those people in their homes longer. I think that's a real need in all 3 of our communities. And I think it's something that will be sustainable long-term and be healthier for our community as well as we go by. So that is something that we're looking at, and we're also working among all 3 counties on community paramedicine and what that looks like. And that, to me, that's a stepping stone to this senior, working with our seniors and community health workers in our communities. We have received in September, we received the CDC DOH grant that went out to communities for $370,000 for Asotin County and $370,000 for Columbia and Garfield County. And we're just putting projects together for that funding, which is around COVID-19 related, COVID-19 effects that are coming, and emergency preparedness for being ready as we go forward. So 2 things that we're ready to start the funding on is a COVID-19 hotline in Asotin County to enhance. They've had an existing hotline, but not a manned hotline. And this will, not a full-time manned hotline. And this will allow for more online, a manned hotline at longer periods to, again, be accessible to our community over there. And that's real valuable because a lot of the people that are calling the hotline are senior citizens and can't keep up on the ever-changing world of COVID-19 regulations and rules and where to go and what to do. And I think that's a real benefit to that community, along with, adding more media outreach as we go along. The other one is we have a physician's assistant in Asotin County that's interested in some long hauler education, so that they would be a person that we could go to for information about what this COVID-19 long hauler looks like as we get into more and more clients in that area with those symptoms, and are these long hauler symptoms, and then have that training be available to also Columbia and Garfield County. So maximizing our use, maximizing our 3 counties and the tools we have. We have a hospital in each county, and just maximizing our efforts among each other, I think is a real benefit of where we're going with that funding, which I am looking forward to. So I think we've done well with getting started with funding for the first 18 months here. Go ahead to the next slide. And, we're looking at, future funding and future plans, just like the Robin and the other LHINs are already in the process of doing these things. And we're on the beginning end or the second session of our assessment, since we have already worked on it once. So doing a coordinated assessment through all 3 counties. And doing that over, multiple year process of doing health assessments and then doing community health improvement plans, and kind of continue on a process over multiple years to keep that data current. And then working on community health worker funding, again, for the focus on the needs of our community, but again, our seniors as a real focus in each of our communities, and keeping them in their homes. And what does that look like? That could be as simple as, somebody carrying their groceries in for them. They went to the store and got their groceries, but just not strong enough to get them to the house. I'm looking at just things like that as we go. And then our group health funds that we have are not date driven. So once we use our CDC and DOH funds, and we're using the group health funds on things that don't fit inside that box and are on an as needed basis. We have used some of the group health funds for behavioral health in the schools and things like that. And then applying for grants on an ongoing basis. Robin mentioned HRSA grants and things like that. And we did get our original HRSA networking grant to get started, but look forward to really working on the next stage of that HRSA grant to move some projects forward in our communities. But my first plan after 4 months is building the trust and continuing to build the partnerships that we will need to be sustainable as we go through the future. So I think one more slide with my contact information, and that's the information I have for you today. Happy to answer any questions about CWA, Southeast Washington Alliance for Health.
Yes, Martha, thank you so much. We do have a few minutes if people have questions of Martha and CWA. Did I get that right? CWA. Over its short existence. And so we still have a little bit of time. Martha, I just, while people are putting their thinking caps on, I say this has got to be a bit of a challenge for you, because not only are you dealing with a small population, the smallest of all our LHINs, but you've got 3 counties. And I don't know if you've got the problem of Kirk's, where he might want to change the border or the boundary. But, I've had some experience working in multiple counties, and I think it presents some unique challenges. I don't know if you'd like to speak to that, or if that's too politically sensitive to get into.
I really haven't had, the partnerships have been great. And building them over the last 5 years, I think before officially coming in alliance has helped that a lot. Help with the trust factor among the different counties. It helps to be from the area and living in the area most of my life, so that I'm aware of a lot of the partners and have outside connections with the partners in other areas. But really, I really haven't had as much of a barrier there, and appreciate that.
Oh, that's wonderful to hear, because geography does matter sometimes, and there may be just some unwillingness to accept that you're working for the greater good of all 3 counties. So happy to hear that's not the case. Anybody with questions of Southeast Washington's Alliance for Health? Not really a question. This is from Hope Baker in the chat, but sharing resources between counties to ensure needs are met is just awesome. There you go.
Thank you. Yeah, I think it was a benefit to all 3 counties as we went through this.
Right. And Sharon just wrote that there probably are silos, and that you continue to tilt against those silos with all your good efforts.
Mm-hmm. Thank you.
All right, well, let's move on then. Oh, wait a minute. Nice pat on the back here from Jolene Carper. So you can read that in the chat, Martha. So that's good to be that continuing connector. So Amy Osterman will give us a report out of Walla Walla for the Blue Mountain Regional Community Health Partnership. And Amy, are you there?
I am there. Can you hear me?
We can hear you loud and clear. So
Awesome.
the mic is yours.
Thank you. All right. So Walla Walla is a little different than some of the other community health partnerships in that we are not a nonprofit. We are still run out of your local health jurisdiction. I know a lot of you have partnerships with your local health jurisdiction, but I, as the coordinator, am actually an employee and the epidemiologist at Walla Walla County Department of Community Health. So that's a little different. So before I go through the sustainability plan, I just want to kind of put that out there because I have been very concrete in that, and the way that we do things is a little different because we're not a nonprofit. So go on to the next slide. Okay, so first thing I did when Carol started talking about a sustainability plan, I was like, okay, what is the partnership doing? How can I sustain it? And how can the partnership do that given some of the boundaries that we have being in local public health? So yeah, we need to maintain a facilitator. We needed to continue our monthly health partnership meetings. We wanted to be part of the drive that the community has asked for a resource directory, to participate in the coordinated information exchange, to support 211, which has struggled somewhat in Walla Walla County, and then also to continue our community health improvement planning and to be a hub to offer training opportunities. And all this was built on our original mission and purpose of the Blue Mountain Regional Community Health Partnership, which was stated as a hub for community related health topics around the community health assessment, the community health improvement planning, and the vetting of community regional concerns on health and social determinant of health topics. And in Walla Walla, that's a little interesting because although we are not a nonprofit, there are several groups in our community that are quite active and are nonprofit or other community service groups that work on some of these community health needs and social determinants of health issues, such as our reach out group. We have the Council on Housing. We have a behavioral health council, and I'm trying to think. And then, yeah, there's Early Learning Coalition. So there's quite a few, and they all kind of meet under our umbrella. So next slide. So I really taking this very literally. I was like, how are we going to continue to do this as a community health department? So I have gotten our administration to agree that our carve out for our foundational public health funding is going to continue to have someone at this department coordinating the convening. So we're doing the public health convening role for the community health partnership. So that means that those funds are secured. And one of the things I feel strongly about that we can offer as a community health department doing that is then I'm not competing for grants that those other agencies could get. I'm not looking to fund another nonprofit. Naturally, we're going to do convening and assessment, and then we're going to rely on our partners to do the social determinants of health as is appropriate with the current nonprofits and community efforts that we have. So if the Early Learning Coalition is running something that we can support, they'll do that. If Reach Out is doing something, they'll do that. If all the different housing groups and the Housing Alliance are doing something, then they'll do that. But we'll just do the data piece. Another piece that I didn't have when I was developing this PowerPoint that I do now have is that I've got the administration to agree to back us using the VMSG dashboard to organize our community health assessment activities. So and that would be a dashboard and a program that will allow community partners to enter their data on their progress for the objectives that go into the community health improvement plans that are based on the community health assessments. So I know that we've all struggled to see what we have done and how we've moved the needle. But I met with them yesterday and the department agreed that it was a good cost. And so for an initial investment of an hour to train and then 5 to 15 minutes a month, our partners will be able to tell me exactly what they're doing and what we've done. So the other thing that I am developing is I have spoken with the Blue Mountain Community Foundation to talk about allowing donations to be received for the Community Health Partnership so that we can expand some of the trainings and other things that we're doing. That's a relationship we need to have because we are a local government and we can't collect funds like a nonprofit would. So that's a little bit of a reach around. So you can go ahead and go to the next slide. This talks about what we're actually doing. So I talked about we're doing the budget. I talked about we're doing having 211 present at our meetings. That's an active focus for our partnership. They have asked for that and we've continued to work with Joyce. There's a little bit of a gap of people seeing how they're going to be able to use 211, but we're continuing to have those discussions monthly. And I think the community is really beginning to see the benefit of that. And we're also continuing to have open discussions that if 211 doesn't work, what are their other suggestions? I'm currently working on the CHIP, on the Community Health Improvement Plan, and we have a committee of folks from the LHIN that are working with me, and then we're going to bring that back to our Community Health Partnership group. And then, as I said, we're in conversations about that fund. So that is pretty much what we're up to. Like I said, we're different because we're a local government and we're really trying to stay in that lane, but also trying to make sure that this is something that is, it'll be here in 5 years, 10 years, 15 years. We'll still be here being that convener, being that data collector, and then supporting those other nonprofits and getting out of their way whenever we can. And next slide, I think that might be it.
Okay, thank you, Amy. That was short and sweet, but let's stay in Walla Walla for a bit and see if there's questions. Because you are in a unique position being a government entity, or that's who writes your paycheck, and I would assume that is then somewhat an influence on your ability to engage in community betterment, community health improvement. So any questions from the group about what it's like, of Amy, of what it's like to do this wearing a government employee cap?
Excuse me, this is Kirk. I know that you just completed your community health needs assessment. And I just wonder what you learned that you could pass on to us because we're a little behind you.
Right. So we partnered with Providence St. Mary's to do that. However, we intend to do a community-based health needs assessment in the coming year. So that was difficult, Kurt, because it was during the pandemic. So we were not as involved as we normally would have been. The one thing I would say about learning about that is don't do it during the pandemic, because they also got much less response from the community because of that. So the more you can wait until things get back to normal. I noticed when they did our community health assessment, it sort of all the usual suspects were there, and I worried if things were missed. And that's not any sort of fault of Providence St. Mary's folks that did it. I know Hazel's on this call. It's just, it was an artifact of the time in which it was done. When we looked at things, also, we found many of the same things we have found before. And so things had changed in some ways during the pandemic. Some things had gotten worse. Access to care has probably gotten worse. But a lot of things were relatively the same. And I don't know if Hazel, there's anything I'm missing that you want Kurt to know about.
Good morning. I think you're doing a great job, Amy. Amy has been fabulous to work with. She's an epidemiologist and she doesn't miss any details. She's amazing.
Well, thank you. I appreciate that. Nice. That the partnership with Hazel and then Karen Hayes with the Providence folks who do the community health needs assessment, that whole team there has been amazing. And I would just encourage folks as much as you can to access the resources that are already there.
We have the benefit of Hazel and Karen as well.
So looking forward, Amy, financially, you think that there is a combination of support from the county and then with some fundraising that you'll be able to continue your work in these, what, 5 different areas that you spoke to?
Yeah, we think we'll be able to support the work in these 5 areas, and then by focusing just on these convening and assessing tasks, that we can stay very clearly in our role and not veer from that. That's really important to me, so that the community, those in the community who are nonprofits, can fill those other gaps.
Very good. We have a question from Suzanne and from ACH. I'm sorry, from HCA. Love the summary of areas of emphasis in the high-level plan. I also appreciated that you were discussing how to measure impact. Will you comment on the status of this element of your work?
Oh, measuring impact.
Right.
So
that's the way I interpret that. Yeah.
Yeah. So I recently met with the leads who are in charge of the different plans that we referenced in our last community health improvement plan. So I met with folks from Reach Out for Behavioral Health, and then I met with the Behavioral Health Council folks. And I talked with the Early Learning Coalition, and then the person in charge of the 5-year housing plan for the county. And we reviewed the goals that were set out in that plan, and then which goals were never started, in process, and completed, and gave a brief report that the community health improvement plan committee will meet about. I'm trying to schedule a meeting, first in-person meeting with those guys. Very excited about getting people meeting in person again. And so what was interesting about those meetings is having to assign, did the needle move or not? And if it did, how do we know that it did? We didn't have as much of a structure going into this assessment as I might have liked about actual benchmarks, but we used what we had to create those 3 categories. And we found we're probably, I would say, 60 to 75% done. And we still have another, year and a half. So I was pretty pleased with our progress. There were several assessment goals set out that they were able to complete, several relationships that they were able to form. They restructured the Reach Out board to incorporate zero suicide and Reach Out, and the CPWI, the Walla Walla CPWI coalition. So that really worked well.
Amy, will you comment on how you're kind of creating these measures of impact? The reason I'm asking this is I'm really curious as we enter into a time when we are seeing a lot of interest in workforce and a lot of interest in spending some money to do some impact, to make impacts, which is really positive, and I'm excited and pleased to support that. I wonder, as I sit and look at that, how we will know that we made a difference. What did we do with the money we spent on this workforce activity to make a difference, at least in supporting community agencies and community providers in making some forward steps? Do you have any thinking about that?
Well, the thinking I have mainly about that is going to be, you're going to need your process goals and then your sort of achievement metrics. So you're going to have the goals that show, did you go through the process you intended? And then at the end of the day, what did you achieve? So, did we go through the process and we hired five of this different health professional or brought them to the community? And then was the work effective? Did they end up serving their clientele? So the first part, did you get them here? Second part, did they get to their clientele? So it's about setting up that evaluation framework when you first start, which is hard. And I think it's worth spending the time. We didn't get enough development time on the first iteration of our plan to do that clearly, but that is the goal going forward.
Yeah, and the sense of urgency that exists, which is very real and very important, is really presses on us to think about how we can do this. I like your allusion to process goals and action goals. If you don't mind, I may connect with you later as I start to think about how to do this work and where we might put it. I probably will talk to Dan. Dan is on the line. I'll talk to Dan, and perhaps we'll talk to our friends at the Center for Health Workforce Studies at the UW about how to do this kind of work, because there's so much money coming in and such an urgent cry for help, because people are really overwhelmed, particularly on the behavioral health side, that I'd like to be able to say, we spent this much money and had this happen, and beyond just, I put this many butts in a seat for trainings.
Well, right. And how did you really expand capacity in a meaningful way? Because I know one thing that can happen, and I've been working here in the community for a while now, is that you might start a new program, but if an old program closes, shuts down, or shrinks because of the new program, you haven't really increased capacity. So it's about the overall community capacity. It's very complex.
It is very complex. Thanks for pointing that out. I would not have thought about that. Thank you for answering my question, and thank you for getting me here.
Right. More questions of Amy and the Walla Walla experience and the 5 different areas that Blue Mountain Regional Community Health Partnership is looking to and has been working in and will continue working in. Okay, then I'm going to pose one question to you, Amy. Tell us a bit about the challenges with 211 and the CIE. You mentioned that something.
Yeah.
That's a big lift for a lot of communities, and I would imagine it's not too different in Walla Walla.
Right. So Walla Walla for a long time had the printed resource directory, and the printed resource directory that it was actually published out of County Human Services years ago. So they really loved that. And then they decided that they needed to move into the 21st century. So I think about 5 or 10 years ago, they did the One Walla Walla app, and it was a phone app, but it was basically a static app. And the city of Walla Walla did that, and all the nonprofits would update the city. Well, then the city had to put that project down. I believe the person that was in charge of it got moved on to another assignment or something like that. So then that app got stale. So then there was a movement that started through the community health partnership, just with people talking to each other. It wasn't a stated goal at that time. How do we update the resource guide? And so they thought, oh, well, we'll just update OWL. And then we got into the details of how to do that. And through our work with GCACH and the promotion of 211, thought, well, that seems duplicative, because people are calling 211 and not getting all the information because the providers are working to update a city directory instead of 211. So we worked with Joyce to do that, and to talk to the members of the committee, and that's been led by David Lopez on our local health improvement plan, and he's a network member. He works for Walla Walla University and the Center for Humanitarian Engagement there. So he took on that project. So he got the old OWL files to see what was in there, and he talked to people to see about how all that would be to revise that, and found that it was really onerous. So he presented that data to the network. And so then Joyce has talked to them about how to update 211. We provided all that information, and a lot of them are starting to get buy-in. But then they wanted that information on their website. So then we talked about Connect 211 and how they might be able to use that. So I think right now it's about people weighing what their investment's going to be and how strongly they feel about it. We're like in a Netherland. And then also knowing that some of the things that they're asking for really have to do more with a coordinated information exchange. They're saying, well, how many people are getting this referral, and how many people are using it, and what happens? They're asking those more advanced questions as they start to think more critically about their referrals and what they mean and where they're coming from. So it's sort of like they're on this evolution. And what I've really been trying to do is provide them the information and the space to have the conversations. And David Lopez has done an excellent job of being able to help facilitate that for our community, along with Joyce Newsom.
Great, thank you. Any follow-on comments or questions about 211 and CIEs for Amy? Something that the Leadership Council has talked about in the past, but we really haven't touched on that recently. And one of the goals of having these sessions is to learn from each other. So any quick comments?
I would be happy to comment. Patrick,
hi, Joyce.
Hi. Just to say, I'm really appreciative of the way that the local health improvement networks have brought us in at the table. I've always had a long-standing relationship with Kirk's group. As Amy said, Walla Walla has been a difficult community only because they felt that they really had their resources very well collected in this OWL app, which, as we know with COVID, everything just kind of went by the wayside as we focused on the pandemic needs. But it really did bring up that need again, that to maintain a database, for it to be accurate and give it out to the public in the most timely, accurate way, you need a team of people to keep that database up to date. And that's what we do at 211. And we've really proven to be very effective during the pandemic to do that, because agencies were closing doors, opening doors, doing part-time services, or, you know, maybe they were doing virtual appointments. I mean, there were a lot of changes through the pandemic that we were able to keep up to date with and inform our communities as they called in for those critical resources. And we've seen a huge uptick in people needing those resources. So again, that accurate information to give out to our communities in need has been vital. And we've pivoted really well to meet that need, as well as manage the state COVID helpline. And so we're really happy to work with all the different local health improvement networks and just say, we're here, we'll support you, whatever they feel is the best for their communities, because that's our goal as well, is to help one person at a time. And I really appreciate Amy's support in the meetings at Walla Walla, because there are a lot of different opinions, and she has left that space to be open for people to just come to their own opinions on it and work together as a group. And we're really seeing some fruition from that. So I appreciate Amy's support on that. So thank you.
Thank you, Joyce. Any last minute comments or questions about the Walla Walla experience to date? All right. I see none. Amy, thank you so much for that that update from the County of Many Waters, and we'll hear from you at the latest in the fall with another report in from all the LHINs. Okay, we're going to wrap up with a move to the northeast from Walla Walla to Whitman County, and that county's particular LHIN, and we're going to hear from Elizabeth. Is it Liz or Elizabeth?
Elizabeth. Yeah, I go by Elizabeth.
Okay, Elizabeth, the floor is yours.
All right, great, thank you. So our LHIN, like every other LHIN, has our own unique structure. Could you move this slide ahead, please? No, well, I guess, okay, quickly about myself. I'm the Director of Social Work and Care Coordination at Pullman Regional Hospital. I am the representative for our LHIN, but I hold no special role on the board. I took on this role, let me say, I think June of last year. So it's been very interesting. I learn a lot every time we do these about all the amazing work you're doing. And it's kind of prompting me to think that we might need a staff member to move our work forward the way so many of you have. It's pretty inspiring. Now, can we go to the next slide, please? Thank you. So these are our member agencies that we cover pretty much all of the county, in even the smaller distant counties, through primarily medical clinics. But having their representation on this board is super important, because not everything in the county stems from Pullman and Colfax. We have a good bit of population in need out there. So this is the group that meets on a monthly basis and sets our agenda and what we focus on at any given time. Could we, and of course, our regional representatives are also Greater Columbia and the Northwest Rural Health Network. Could we move ahead again, please? So this is our, when the Whitman County Health Network was put together a couple of years before Greater Columbia developed the LHINs, this was the driving statement. They hesitate to call it a mission statement, but this was what brought them together. And when we had a conversation about what is our sustainability plan, what would this look like if we didn't have any Greater Columbia funding? I received a lot of energy back about we're not just about money, that this group comes together to share human resources, right? Like, what do we bring to the table that is non-monetary, that inspired us to get together in the first place, and what will keep us together in the long term, Greater Columbia providing us support or not. So that is the non-monetary resources, is coordination of existing resources, because each agency, each group brings its own set of resources and motivations and opportunities. And then together we apply for grants, and then individual agencies, if they have a goal or a project that they want to work on, they have individual funding that they will seek out, but then we will join together with other types of resources to help them promote those. So, and I think that speaks to one of the great things about this health network is and what they really do not want to lose is the flexibility, the agility to respond when things arise suddenly, issues anywhere in the county, that they're really great about coming together and figuring out how to meet that need. So that is a strength, but on the other hand, it can lead to some lack of continuity. So I would say the way that we are structured is a loose web of agencies committed to moving us forward through the long term. So they did not want to focus on money. They did not want to focus on how we were going to continue to fund ourselves. They really believe that the way we've set ourselves up will be sustainable for as long as we find it to be useful, which I don't see any reason that would come to an end. So, okay, next slide. So our biggest project right now, which involves several of the agencies, Community Action Center is the lead, Public Health and WSU and the Pullman Regional Foundation are all working closely together to do our community health needs for 2022. So the focus questions this year are, what do our communities value? What are the needs? What resources do we have already to meet those needs? And then what have the effects of COVID been? So tagging onto this, another project that we're working on is Whitman Hospital and Health Clinics got a DOH grant to focus on the effects of COVID. And what we're doing right now is starting a telepsychiatry program for the outlying county, stemming out of Whitman Hospital and their clinics, which cover St. John and Tico. So really get into the heart of the county. And one of our biggest needs is psychiatric providers. Our county has one psychiatrist and a couple ARNP prescribers. So the need is great and hard to meet. So we're initially putting money into that, but the rest of that planning will come when we have the results of the community health needs assessment, so that we know what the greatest needs are all around the county. And next slide, please. Now, some of you may think this is boring, but I find it super fascinating, the time and effort and energy that goes into community health assessments. I didn't pay any attention 2 years ago, I'll be honest, I just didn't. I saw the results. So now being more actively involved and seeing just what an amazingly big project this is, if you want to get good results, right? If you want to get the most information from the most amount of people, it takes a lot of time and a lot of manpower. So June, July, the community survey will just be released. And then also in that time frame, a little later in June into July, they'll have public forums. assuming by that time that we will continue to be free to have groups of people come together to talk about these things. So then in August, so June, July, all that information will be gathered, paper surveys, electronic surveys, and then in-person meetings at various locations in the county. And then August, everything will be gathered up and the report will come out in October. So, I mean, that is just, and they started this work in February. So that's a long time to put into this. And I just think it's amazing. And then from that, we will look at the DOH grant and decide how we can use some of that money to address some of the needs that come out of this survey. Okay, I think I have, oh yeah, this is the other thing that we really focus on in the last year here and will continue to focus on for 2022 is transportation. It is a big issue for us in our county, getting people to whatever appointments they have, health appointments, mental health appointments, WIC appointments, going to your public health office, you have to come to Pulmonary, you have to come to Colfax. So transportation is something that we have always struggled with. Well, this year we started the gas card program, which we modeled off of the one out of Stoughton County. And, or maybe it was the Southeast Washington, the whole LHIN down there. I'm not exactly sure. But anyway, it's been very successful for us. It's been particularly helpful to the outlying health clinics and to our mental health partner who covers the whole county, and be able to have access to gas cards with no strings attached other than what they think they're useful for. And the other thing we did was invite Coast Transportation. They're now an official member of our board, and we were able to give them some grant funding to increase their transportation. So we address several things by dealing with transportation. We address access to medical, access to mental health, but we also can help reduce isolation and loneliness among people who live out in the county, not embedded in the community. This can allow you to come into senior services. You can go to church. You can get transportation with this increased access for many things that in the end up addressing a lot of other social determinants of health. So that is it.
All right. Thank you, Elizabeth. Some questions of the Whitman County experience for Elizabeth.
Elizabeth, would you talk a little bit more about the gas card program that you're running and how that works, and particularly about distribution?
So we purchase them in bulk from a local, I'm not sure if this is the right word, but distributor, right? They own a gas, one of those gas companies. And so they gave us a really great rate. So we buy them in bulk, and then we distribute them to any of the board member agencies who want them. So medical clinics, the mental health center, community action center, and then we just have a form that we fill out to track them where they went. And there's a couple, I wish I had the form with me so I could tell you what's on there. So then they're given out through the clinics to people that they know, right? So the mental health agency has chosen to use them also, not just for people coming and going to appointments. I know this isn't the question that you asked, but I think it's important to, like, when you talk about distribution, what are we actually doing with them? We're using them, this agency is using them as incentives for engaging in treatment goals. So the distribution is based on whatever that particular agency feels that they're best used for. What is the biggest bang for our buck in giving somebody a gas voucher? So then they just, while we bought them from the distributor, they can be used at any gas station. So
that was my next question. Thank you.
Yeah.
Martha, you mentioned you're doing that as well in Southeast. Any quick comments or comments from anybody else using some of the funds to help with transportation?
Yeah, thank you. It's been a real benefit to all of our counties, specifically, I think Garfield County. We've had people that needed to drive to Spokane for medical needs. We've had babies in NICU in Spokane and had to go up multiple times and did not have and use the gas vouchers for that. We've had people from Columbia County, I know, go to Seattle for medical reasons. And we have somebody now that is going from Garfield to Columbia County to the special wound clinic in Columbia County. And we are helping provide gas cards for that. So I think they've been a benefit. The dental clinic has used them for trips to the dentist office in Chaz Health in Clarkston. You know, just numerous different ways that aging and long-term care has used it, just numerous different agencies with the form. The form just has our form has to have a medical appointment within 4 days and has to show that they have a driver's license, that somebody that driver's license that we know they're going to use the gas card to get there legally. So it's something that we've had for 2 years now. We put enough funding in for 2 years and it just been beneficial. Thanks.
All right, thank you. Yeah, so there's 4 counties and within the boundaries of the Greater Columbia ACH that are using some of the monies for transportation. Any other questions of Elizabeth?
I do, Patrick.
Okay.
This is Joyce. I just wanted to check with Martha and Elizabeth. That's fantastic. Love to hear about transportation needs being met. Are you also able to assist with bus passes? Have you had any experience working with your transit companies that way? Because not everybody has access to a personal transport vehicle or a friend with that. So I was just wondering if you'd had any feedback on that.
Well, that's why we also gave money to Coast, because we own the buses in Pullman, right? So Coast is really important for us, for people who don't have cars or don't have driver's license. So we utilize Coast heavily. In Pullman specifically, we have Dial-A-Ride, and that you qualify through medical issues or you can buy tokens. And so, yes, we buy tokens for people, but that's limited to Pullman, and so is the bus system. So that's why gas vouchers for us and Coast are really, if we're going to cover anything outside of Pullman, we have to have those 2 resources. Okay, perfect. Thank you, Elizabeth.
And if we've had people that have wanted to use public transportation, we've used this on a case-by-case basis and tried to accommodate whatever they need there.
Okay, thanks, Martha.
All right, any last minute questions from the floor of Elizabeth? Well, I've got a question then, the same question I had for the 3 presenters before the break, for all 3 of you, from Walla Walla, Southeast, and Whitman. And that is, how do you know that these endeavors are making a difference? What have you done in the area of tracking with data? I think we heard a little bit from Amy, but perhaps she can elaborate. And any comments from Martha or Elizabeth would be welcome.
Well, I'm just going to be forthright and say, I don't know. I think each individual agency is collecting data on what they're doing, and it may come back to the network as a report out, but the network as a whole does not track that itself.
Okay.
which is again one of those reasons I'm wondering if maybe it's time that we move to a system of having an actual staff member who is responsible for doing all that. But at this point, there's nobody who has the time or capacity to manage the network endeavors in that way. So I'm afraid I have nothing to tell you that's helpful.
Well, I think that's a common response, especially given the size of the county. So I wouldn't feel badly about it. It's just what it is. Martha, do you have, or Amy, do you have any comments to that?
I think on my side is the way I think I'm measuring it is the trust that we are building. Since we're a new LHIN, it's the trust that we are building in the community. The increased people that know about us, the increased people that are asking for the gas cards, the connections that they are making, that and coming forward to the network and saying, hey, I heard you're doing gas cards, can we be involved? And that's how I'm kind of gauging it in our community is the increased community involvement.
Okay, thank you. Amy, any comments from your end about how you're measuring whether the needle is moving?
Right. So I like what Martha said about, building trust. And I think there's something about those intangible, building the spirit of the work. And then just going forward, hoping to build the metrics in as we develop new programs and the accountability to the community health partnership about how they will get those reports. Because I know that that's going to build those intangibles, the trust. So if we say these are our goals and here's how you'll know when we accomplish them. And one of the things, we've got a new communications person here at the county and thinking about how we can display that on our partnership health page so people can go in and see, and they can show people in the community, look, I'm part of this group and here's what I've done. So I think we can get there, but we're not there.
Gotcha. Right. Yeah, no, it's a big lift trying to do that as one who gets involved with lots of data projects. My second question that I had for the first three presenters is also I'd like to pose to you all, and that is if you could wave your magic wand and be St. Patrick finding the end of the rainbow that would do one thing to elevate your efforts in each of your communities, what would that be? One barrier to overcome, to climb over. Anybody have some thoughts on that would make your work a lot easier and be able to show actually, whether you measure it or not, that the needle is moving?
I think the one thing that we talk about in a lot of our leadership meetings and have over the past 5 years is community health workers and being involved at every level in the community where and meet them where they are. And I think once we can see those community health workers actively in our community, we will be able to see tangible differences throughout.
Okay, and I take it, Martha, that at the moment you don't have community health workers at your disposal.
Correct.
Okay, all right. Elizabeth or Amy, any thoughts? I know I'm putting you on the spot to prioritize things, but I think it's always interesting to see what we might come up with and learn from each other.
I think one of the main things down here is we've been in crisis mode, and I need to get the community focused back on the social determinants of health and prevention mode. I think there's a lot right now. We have to focus on what's right in front of us, and those things are important. But I want people to go back to thinking, well, why do we have so many people without a medical home? Why do we have people who aren't engaged in their care? And community health workers can be an excellent solution to that, but it's getting people out of that crisis mindset is hard.
Okay.
Yeah, Amy, I agree with that. That's really important, switching out of being reactive to responsive. And I think for us, finding ways to get the health network more connected in the rural towns. We have so many great things going on, like our libraries are embedded across the county, but they're not active in our network. senior services are active in various ways in many smaller towns, but they're not active in our network. So I think pooling together some more resources to get us further out and better understanding how to serve those small communities, and community health workers might also help us do that. That could do outreach, do boots on the ground outreach, right? Not just collecting survey information. So things we continue to work on.
All right, fair enough. I think those are three very valid points, and appreciate you responding so quickly. So, are there any other questions of our three presenters, or for that matter, from our three earlier presenters? I know that we've had people having to jump off, so we're down to about half, no, 3/4 of the size that we had. Last minute questions. All right. I just want to point out what Stacy put in the chat box, and that is we'd really appreciate for those of you who can just give us a couple minutes to fill out that survey, and that does matter. So please do that. And then since it is St. Patrick's Day, and this is the day when I think about being Irish, I'd like to leave you with a little blessing that I'm sure you've heard before, but it's always, I think, it's a beautiful blessing, and I'll just read it out loud, not with the brogue that I wish I had from my namesake, but nonetheless, I think moving words. Here we go. May the road rise to meet you. May the wind be always at your back. May the sun shine warm upon your face, the rains fall soft upon your fields, and until we meet again, may your God hold you in the palm of his hand. So there we are, St. Patrick's Day, Greater Columbia ACH, and I thank you all for coming. Oh, here we have a last minute question from Carrie. So I don't know whether anybody wants to answer that, but if you do, we'll just leave that open for a couple more minutes. Sharon, as the executive director, do you want to have the last word today?
I want to thank everyone for presenting today. I thought the presentations were incredibly informative, and for everyone who's been in attendance, and encourage you to continue to reach out to us with any questions you may have. And thank you, Patrick, and happy St. Patrick's Day to your namesake, Patrick.
I'm going to celebrate somehow, some way. Yeah, I hope you can too. All right, everyone. Well, thank you so much. Remember the survey, and we'll meet again in a month.
Patrick, oh, I have the answer for that lady. I was just going to post it in the chat, but
Okay,
she probably
go ahead.
jumped off. Well, yeah, okay.
Go ahead.
Sorry, I was trying to pull it up.
Okay.
We got the guidance yesterday for that.
She's still there.
Okay. Thank you, Carrie.
Thank you, Joyce. I was trying to pull it up as well. Okay,
I
good.
know, sorry about that. It was like so quick trying to pull it up. Yeah, DOH provided updated guidance yesterday for where we have to be masked in what facilities that relate to medical.
I'm gonna
All right.
bookmark it. Okay.
Thank you, everyone. We'll see you in April.
Thank you for a great meeting, everybody.